So just wanted to thank everybody. Thank you for joining us. We know this time of year can get a little crazy as we're gearing into respiratory season. So thank you again for taking time to join us this morning. As I'm sure all of you guys are aware, respiratory season is ramping up very quickly. It seems like everybody is fighting some sort of sniffles or cold or flu right now. So again, thank you for hopping on right now. My name is Kira Gibson. I'm our Director of Marketing here at Industry Lab. If you don't know who we are, we're a clinical reference laboratory that focuses in PCR testing and toxicology testing. So it's one of our goals to be a reliable source of information for not only you guys working in these facilities, but also for your staff and for your patients. So this is just one way that we like to do this. If at any point you have any questions during the webinar, you can submit those using this little, it's called the activities icon. It is the icon on the bottom right with the 3 shapes. If you click that, you should see a little function there called Q&A. It's like the 3rd one down the list. You can submit your questions at any point during the presentation, and you can do so anonymously if you prefer. We'll have a session at the end where we go over all of the questions. You're welcome to, raise a hand. We'll get to you there as well. With that being said, I'm going to go ahead and pass everything off to Dr. Michaud so we can get going.
Okay. Thanks, Kira, and good morning, everybody. Thanks for joining us to talk about respiratory and to talk about PCR testing in respiratory season that we are, as Kira said, very much in. If you've been following along or if you've been outside in your community, the COVID numbers, the RSV numbers, kind of the seasonal virus respiratory infection numbers are up across the board pretty much in the last 3 or 4 weeks. So the season is officially upon us. If you've not joined us for one of these town halls before, I am the Director of Clinical Treatment for Industry Lab, and that is an unusual title that you may not have heard if you've worked with other labs before, and it is pretty unique in that we at Industry are focused on being exactly that, a clinical lab. So it's my job to make sure that what we are testing for is relevant, is usable to providers, and provides maximum benefit to providers and patients. And part of that role is doing this kind of education, which I really enjoy. So we're going to try to touch on a lot of things related to respiratory infections today, and we'll try to get through them quickly. And I appreciate everybody's time this morning. So we'll look first at some recent epidemiology, and especially post-COVID. What does respiratory illness look like now in the United States? We will spend some time to look at the use of antibiotics in this predominantly viral disease state and see some opportunity perhaps for improvement there. We'll look at the available tests that we have at our disposal in the respiratory space and the ones that especially can provide us fast and usable data when we're seeing patients. And then we'll conclude with how we're approaching respiratory testing a little bit differently and why we're really excited about what we can offer to help patients with respiratory infection. So to begin, a brief look at the anatomy, because obviously the respiratory system spans a lot of degrees of illness, from very mild, hardly noticeable, common colds, to very severe pneumonias that cause a lot of morbidity and mortality. And I put this up here just to highlight in the blue boxes here, the viral versus bacterial percentages in terms of breakdown of types of infections that occur at these different sites. And even just to point out that places like the sinuses, where we classically think of bacterial infection, or the tonsils or pharynx area, where we think of strep throat as being a major player, even though in those bacterial sites, we can see that those infections are predominantly viral in nature when we really look at them top to bottom. So viruses play a huge role all over the respiratory tract in causing infection. And this is true in the lower respiratory tract as well when we get into the lung space. And as particularly at the level of the bronchi and the bronchioles, where RSV starts to become a real problem for our kids and for our elderly, still dominated by virus. And really, it only starts to even out when we get to true pneumonia at that alveolar level, where the viral percentage, and they vary a lot depending on population, of course, but where the viral percentage is still presumed to be the highest, followed by bacterial mixed infections in the 10 to 20% range, and a fair amount of pneumonia that's undefined or miscellaneous, things like fungal. So viral is what predominates our lungs and our respiratory tracts. when we get infected. So let's look at some data. Maybe you've seen this before. This is the COVID impact and the shutdown impact on our respiratory season. These are weekly flu cases and weekly RSV cases. And you can see pretty well where we sort of went into lockdown, right? In March, April of 2020, it pretty much stopped the 2020 respiratory season in its tracks. And we really didn't have much of a 21 season at all either, as we were still pretty focused on distancing and masking and paying very close attention to our viral symptoms. This is another way to look at it. I thought this was a really cool interpretation to show the seasonal viruses. We were familiar with the flu numbers perhaps and the COVID data certainly, but what about all these other kind of endemic viruses that make up our respiratory seasons? And you can see how they map here, where it's traditionally dominated by other human coronaviruses, non-COVID-19, and rhinovirus, just things that cause common colds, things that most of us don't ever seek the health system for because they're very mild, but they are very easily spread, as we know. And again, you can see 2020 in here where we shut down, and those viruses obviously grind to a halt as well. And then in the dark green, COVID, as we can see it going up and down. And what we really didn't realize is still the amount of regular coronavirus or human coronavirus and rhinovirus that continue to spread in the background of that. Obviously, our attention is not paid there, and the degree of illness is very mild with those. But to still see them able to spread so much despite our precautions and our masks and our distancing really tells you how able these viruses are to spread between individuals as well. So I want you to think in your head about last year. This is the flu data, again, going all the way back to H1N1 here in 2009. And you can see the spikes every respiratory season and how in general, we've had more and more and more leading up to 2020 and the COVID outbreak. But what do you remember about last flu season? We know in 2021, we really didn't have much. What about last year? Where did we have kind of a small peak season? Did we have an average peak? Get that number kind of in your head for a couple seconds, and then and I'll show you where we actually were. So this was our influenza season last year, the highest ever recorded by a long shot, and the data for pretty much every seasonal virus mimics this graph, that we had more spread, maybe we didn't even realize it, of these viruses than really ever before when we put them all together last year. These are a couple RSV graphs of last year as well that basically emphasize the same thing. This one is hospitalization rate by year. And so down here, you can see 2020's line, 2021's line, which is kind of close to pre-pandemic levels. And this was last year when we presumably were a little more relaxed, a little obviously less masking involved, and maybe a little burnt out on taking heed with viral symptoms. And we saw the effects of that as a population with exponentially higher rates of hospitalization than we have seen even in pre-COVID levels. And this is the same, this is last season as well, broken up by age. And we can see the hospitalization rate per 100,000 in the 0 to 4-year-olds in the kids was, again, they're the population that bore the brunt of RSV last year, as they do. We know this is a predominantly pediatric illness. But this included a lot of kids who have never been exposed to RSV in their first or second year of life because we were in lockdown. So we saw a larger than ever RSV season last year. And this spike below it, it kind of pales in comparison. But this is our elderly population, this green spike over 65 years old. And this was also magnitudes higher than previously. So we're seeing RSV come through in much greater numbers than previously seen as well. And just a few final factoids, and I love this sneezing picture. We've probably seen some version of this, how far you can throw your organisms around when you sneeze. Upper respiratory infections cause 25 million doctor visits per year in the US. The common cold causes kids to miss 22 million school days and parents to miss 20 million days of work every year. And if you have little kiddos in your house, like I do, cough, cough, you're probably sitting in this stuff more often than you realize because they are infected quite a bit of the time. All of this to emphasize, again, what we said at the beginning, that most of these infections are viral in nature. And the 10 or 20% of bacterial respiratory infections many of those are indeed secondary infections that have occurred after an initial viral illness. So our focus really here is talking about how to manage viral or how to diagnose viral illness, because that's what the majority of patients with symptoms are going to have. So what do we look for this flu season as it gets underway, or respiratory season, I should say? Presumably, the assumption is another triple-demic, as it was kind of coined last year when you combine these three. And we may not have felt it, again, if you're not especially in an inpatient system, but hospitalizations for respiratory illness were higher last year even than they were during COVID season, during stages of COVID season, I should say. Deaths were very high from these viruses that generally have not caused such mortality. And so that's what we're looking forward to, presumably, again, this season is the expectation. The flu vaccine is expected to do better than average, based on as we look at the Southern Hemisphere, who's ahead of us. They've seen some good success with the flu vaccine in terms of preventing severe disease. But the assumption is that we're still likely to see a lot of spread and a lot of viral illness in the months ahead. Obviously, today's talk is talking about diagnosing these infections and how we sort through that, but I wouldn't be a good clinical pharmacist if I didn't include a little bit about management and treatment. In terms of COVID and influenza, there's not a lot of new things in the last 12 months or so. Vaccines are available for most people for both of those, and they're recommended as we go into the season if you haven't gotten one yet. And the treatments are generally the same as they've been. Paxlovid, this new molnupiravir, is a newer oral agent for the prevention of severe COVID symptoms that can be given to outpatients. So we might see a little more use of that as well. But the real big changes have come in the realm of RSV, where just earlier this year in May, the FDA approved not one, but two different vaccines for the elderly. And now it is recommended for a lot of elderly patients over 60 that they actually get all three of these, so that when invariably they come into contact with them this season, that they can prevent the progression of severe disease. They also approved, the FDA, a new monoclonal antibody for kids who are entering their first or second, real season, where we can supply them with a little more antibody protection to also try to prevent hospitalization and development of severe disease. So some cool new advances in the realm of RSV. Some of these have come on the backs of rapid learning that has taken place during COVID. So good to see that stuff being put to use, and hopefully we can keep some folks out of the hospital this season because of these new medications. So let's get back to viral. We know we've spent a lot of resource and a lot of time trying to educate the medical community and the patient community at large that viruses are common and antibiotics do not treat viruses. And despite that being common knowledge in probably our realms, you don't have to look far to find data after data after data that say we don't do a great job of treating to that effect, and that we still prescribe a lot of antibiotics for viral infections in the United States and really around the world. And I want to highlight the problem that this is. I mean, we see 40%, 50%, up to 70% in some of these studies of unnecessary antibiotic use. And so I want to take a little bit of time to unpack why that is, why that's a problem, why we should all be sharing the responsibility to try to do better here, because it leads to real world ramifications that we just might not be seeing in our day-to-day practice. This is one of many good papers that tried to highlight kind of the risks associated with overuse of antibiotics or unnecessary use of antibiotics. And this does a nice job of going through the data that supports this. And again, at a very high level, I just want to highlight some of this. Number one is that antibiotic use hastens the resistance that we see in our community and in these bugs. It's pretty intuitive that the more antibiotics that you give to either an individual or a community, a population, the more that you select for the more resistant bugs to become the dominant species. And this graph down here just looks at one type of resistance, the resistance to beta-lactams with those beta-lactamases enzymes. And you can see in the last 20 years, just an exponential takeoff in new development of genes that these bacteria create. They are smart, and we are in this period right now where bugs are getting smarter faster than we are developing new drugs to treat them. And if you spend any time in an inpatient space like I do, in an emergency space or a critical care space, some of these bugs are just devastating in what we have to give to try and treat it, because there are very few antibiotics left for some of these resistant infections. So certainly reducing our antibiotic use can help to slow this resistance development. The next would be complications of antibiotics and risks here. I don't probably need to tell anybody about the risk of C. diff, though I would highlight some of this data if you've never seen it before, which is interesting. Some of this is an outpatient study that showed a simple 10% reduction in outpatient use would generate a 17% reduction in C. diff. That matters. We know that even one episode of C. diff has a lot of patient implications, sometimes even mortality implications, let alone healthcare costs and all of the rest. So a 17% reduction would be a great thing to see. This next study was an inpatient study that echoed a 30% reduction in the broad spectrum antibiotic use on the inpatient side would save up to a quarter of C. diff infections. And this is just, again, one example of antibiotic-induced kind of harm, if you will, that we could limit or we could reduce if we could be a little bit more conservative with our antibiotic use, especially for these viral infections. Another side effect, essentially, that we probably don't think about. Antibiotics account for about 20% of all drug-related emergency department visits. So there's a lot of people showing up to the emergency room with symptoms and side effects from the antibiotics that they got for their viral infection. That's just the reality. Whether we have seen it as individuals or not, we know that this is happening. A lot of this is allergy, of course, but a lot of this is just the other side effects. When I teach pharmacology or drugs to pharmacy students or medical students or anybody, I usually tell that drugs are poisons with occasionally beneficial side effects, right? And if you've ever looked at a package insert for a drug, it's just a laundry list of known risks and known bad things that these drugs can cause. So anything, again, we can do to be better stewards of these antibiotics will help to limit these unnecessary adverse reactions or side effects that are caused by these antibiotics. So we know all of this. Probably none of that is new information to anybody on this call. So why is it that this is still so hard to draw a line in the sand when we know so much of these infections are viral? Why is there still so much antibiotic use and therefore antibiotic sequelae? There's been some good data looked into this, and some of this behavioral science will tell us the number one reason is patient satisfaction and pressure, because this unfortunately matters now in today's healthcare. And here's a couple of studies. One of 8,500, I just took some snippets here, 8,500 patients, outpatients with respiratory symptoms in one multi-centered practice. And they looked at how prescriptions affected their 5-star satisfaction scores from their patients. And you can see if you prescribed an antibiotic or if you prescribed something, right? If you just said, here's something that I can give you to make you better in a predominantly viral illness, you were about 90% likely to get a 5-star review in terms of patient satisfaction. If you were more likely to say, you probably have a virus, there's nothing to take or give you, please go home and rest and you will get better, almost a 20-point drop in 5-star satisfaction. And unfortunately, this drives things in our healthcare world today. So this matters. This is another study where each of these dots represents a physician over time. And you can see the line's not perfect, but there's a general correlation that the providers who have a higher rate of prescribing antibiotics for respiratory tract infections got higher satisfaction scores. So it is what it is in today's healthcare world. But we should acknowledge that it is what it is. And this is a reason why we give a lot of unnecessary antibiotics. The number 2 reason was time. And they comment, they may quickly prescribe antibiotics because they want to avoid lengthy discussions of why the drugs are not needed. Consider that paradox. And there's a lot of data to show that patients or providers who see more patients in a day with respiratory symptoms are more likely to prescribe antibiotics than those who are less busy, who see fewer patients. Again, kind of unavoidable. This is what the healthcare system pushes on us to see more and to see faster, but it is a risk and it is a cause of this problem. This was just, again, one study, 260,000 encounters. The number one reason for inappropriate antibiotics, or the number one predictor, was length of provider time. And they said for every additional minute spent with a patient, it yielded, it reduced the odds of unnecessary antibiotics by 2.5%. So that matters when you think of the millions and millions and millions of encounters that we're going to have in various settings for respiratory symptoms. Number 3, decisions fatigue. And the data shows pretty convincingly that the same provider is more likely to prescribe antibiotics later in the day. And I guess you can just imagine you coffee in the morning and you're ready to fight the fight. And by the 10th or 12th or 15th patient with the same symptoms, you just have a little less ambition to take a hard line and a hard stance on not prescribing antibiotics. Number 4 is uncertain diagnoses. And they comment, this is true, right? Viral and bacterial infections look the same. So it's hard to differentiate when there's not a good test to help you differentiate. And we'll certainly unpack this one as we go. And it holds hands with number 5, fear of deterioration. We know that most of these infections are not bacterial, but what if this patient is the one that has that bacteria, is going to develop a pneumonia, is going to get really sick, and I want to prevent that. So I'm a little more liberal with my antibiotic use, and that's real. And number 6 that this paper points out is that we assume other people are the problem. We acknowledge there's an issue, we need to do better, but it's harder to see that in our own practice sometimes, and that's very fair. So a lot of reasons why, despite everything we know about the ills of overprescribing antibiotics, it continues to be what is standard practice. This was just a good paper to highlight that was published in JAMA Network, a big paper, obviously, or a big journal, obviously, and it really calls this issue out, and it puts the onus essentially on 3 groups: providers, who are kind of the boots on the ground; healthcare leadership, to be auditing this, to be emphasizing antimicrobial stewardship and rewarding good stewardship; and ultimately payers, to try to help emphasize the need for better antibiotic stewardship, especially in this realm of respiratory infections, where we know that they are so often unnecessary. And so with that background and information in mind, I want to transition to how do we currently diagnose this stuff? How has industry lab taken essentially that call to action? And they don't call out laboratories specifically, but we kind of looked at that and said, what can we do to be a better tool, to be a better resource for providers to try and positively impact this problem? And so to start, I'll just show some very elementary information. And this is just a CDC algorithm. There are hundreds of different algorithms that generally say the same thing, to try and say which patients should we be thinking antibiotics. And as you can see here, when patients come in with these generalized upper respiratory symptoms, there's a pretty small list. Have you had long-lasting symptoms? Obviously, is it ears? Is it strep throat? Things that, kind of automatically push you towards antibiotics. And if it's not one of these things, we should really be pushing. You likely have viral illness. You probably just need to wait this out. You don't need an antibiotic to get you better here. More of the informal checklist, and this was just sort of put together in querying some primary care colleagues of mine. They say, obviously, what we want to know is, do you have the flu? Do you have strep? Do you have RSV? Obviously, now COVID is part of that bundle for a couple reasons. One, there's some specific treatments that we can have. If we can confirm flu, we can get you on some Tamiflu maybe and shorten your illness. And there's certainly population health and community health things that can be done now for some of these, in terms of staying home or separating yourself from people, wearing a mask, all that kind of stuff. So these are obviously on the top of our minds anytime we're seeing somebody with upper respiratory or lower respiratory symptoms. Then they sort of ask themselves the question, is this patient high risk, right? Ultimately. And this is just a very qualitative list of some of the populations that you would look for. Are they very old or young? Are they immunocompromised? Kind of to say, if this person has bacteria, are they at high risk for getting really sick? And if they are, then I tend more towards antibiotics. Even if I think it's viral, that's just how I'm skewed towards this. Even though the data is not overly supportive here, this is what happens in real practice. And in theory, if you can make it down to number 3 with answers of no to these things, then we just have to sort of assume that it's viral, try to get a patient to buy into the fact that it's viral, and try to manage them appropriately. So what supports can we give? Because those are otherwise very qualitative and sort of subjective assessments that rely on the exam and on the history. We're all likely familiar with some form of a point of care test. Most of these are rapid antigen tests, though, especially in the last few years, we've obviously seen PCR enter the point of care space. When we talk about COVID testing and now influenza testing and some other mostly one-off, single organism type tests. But the bulk of what we have had for a while are rapid antigen tests. So these have a lot of appeal to them, especially for in-office settings, because they're easy to use. They're pretty cheap, they're widely available, and you get results pretty fast. And you put this on the machine and 15 minutes later, you can get a result. Obviously, this becomes a problem sometimes during respiratory peak season when you have to run 20 or 30 or 50 of these things in a day, and you've got to keep cycling this machine, and you've got a permanent person kind of just rinsing and repeating there. But in general, these machines are very nice for these reasons. The main drawback is the sensitivity of this technology. And you can see the variance here. Different tests, will tout different numbers. But in general, the sensitivity is considered to be fairly poor. And that translates into you getting false negatives. So you look like you have the flu. I'm going to do this flu test in the office. Sit right there. I'll tell you, this says that you're negative for the flu. Well, what do we do now? And in some cases, that means, well, this says you don't have the flu. So I'm going to treat you like you have something else. And you're pretty sick. So here's some antibiotics just in case. That's a very logical situation. And that's just because the sensitivity of this test is not good enough to detect, in some of these cases, 50% of the flu. So if you look at the inserts for almost all of these tests, they will suggest confirming both positive and negative results with a PCR test. But obviously that's not done all the time, nor is it necessary perhaps all the time. And there's still a great place for this, because if that flu test is positive, that really helps reinforce, okay, you look like you have the flu. This says that you have the flu. We're going to manage you like the flu. And so for these very specific tests that these can provide, they are still useful tools. On the other end of point of care, we have sputum culture. And this kind of rounds out the diagnostic testing that we can do outside of imaging and blood work and that kind of stuff. But sputum culture, depending on where you're practicing, you may use more or less of this. Obviously, we're very familiar with sputum. I don't just mean to harp on the drawbacks. We generally are all familiar with culture. I use culture every day in the hospital where I work. But some of the notable drawbacks are that, one, you have to get sputum. You can't just swab up here and expect to find bugs that are living down in the lungs, because the sensitivity is just not that good. We know that a lot of bugs that cause pneumonia and respiratory infection don't grow well on cultures, especially these atypical bugs that cause a lot of disease. Specimen handling and quality are plagues all the time. You got to get it there, got to get it to the lab quick, and you got to make sure the temperature doesn't change. You got to handle it with care, because we essentially have a living organism in there, right? We think, and we've got to baby this thing to try and grow it so that we can figure out what it is. So there's a lot that can go wrong. And that weighs into the ultimate sensitivity of sputum culture for pneumonia is about 64%, roughly, when you aggregate a lot of data together, with a specificity of only 70%. So this is not a very high yield test, particularly when we consider how long it takes to get results back, generally in a couple of days time span. So are we really using this data anyway, especially in the outpatient world? But again, it's what we've got, and it's really all that we have. So it's what we use, and it's what we've used for a long time, but it's worth coming face to face with the reality of this not really being a great test for these patients with symptoms. So the case for using PCR is very strong in the respiratory space. PCR, if you're less familiar, we're not really diving into the technology, but this is now molecular medicine. This is DNA-based, patient-specific medicine, and this is where we are in the technology now and in the advances. And because of that, we can test for viruses and bacteria and atypicals and fungi and spirochetes and you name it. If it has DNA, we can find it on PCR now with incredible accuracy, sensitivity and specificity, both above 95%. And there are almost no other infectious disease diagnostics that can say both of these. Right? Some are very specific or some are very sensitive, but it is rare to see such accuracy on both the positive and the negative side of a test. And ultimately, PCR is pretty fast, especially when you compare it to something like culture, where we're talking about days. These tests, even in their broad packages, only take a matter of hours to run. And again, some of these single tests, like these one-off COVID tests and things, are available in very short order. So there's a lot of things to like about PCR in the respiratory space. And in theory, using these accurate PCR results that we can get in real time, in timely fashion, to actually do something for this patient should help our antibiotic stewardship by a couple of things. One, ruling in viral infection, right? Instead of saying, based on what I'm seeing here, you probably have a virus. That's often, as we've seen in the data, not good enough for providers, and it's usually not good enough for patients either. Versus being able to say, here's a test that says you have parainfluenza or you have metapneumovirus, adds a little more strength to that diagnosis. It can be further strengthened when we can test for bacteria as well, to say, yes, you have a virus, and no, you do not have bacteria, confirmed, with really, really high accuracy. This is going to justify our reason to not treat you with antibiotics. And I think this can go a long way in some of these spaces to convince providers, or just to help that discussion that otherwise doesn't have a lot of concrete information to use in supporting those diagnoses. Finally, we can test for antibiotic resistance markers as well by their genomes. So and it's in the same 5-hour test, 6-hour test that we find the bugs. So in very rapid order, if there is bacteria in there, we can say, here's what it is, here's what it is resistant to, presumably, so here's how to manage it. And when we do need antibiotics, we can make sure that we're not just giving everybody big, broad coverage, because we know there's a lot of perils to that, but we can be more targeted in our approach. So a lot of good ways that this can add to our antimicrobial stewardship. I want to just touch on the data here because this is important, and this is where I live. I love this stuff. We could spend an hour easily unpacking all of this by itself. And I'd love to do that if you ever want to call and talk about this more. But in summary, there's data in a couple of categories, essentially, where it's been done. And a lot of this has been done in the inpatient space so far, where patients are a little sicker. But the first set is viral multiplex PCR. So they've got a test with 8 viruses or 12 viruses or what have you. And they say, we're going to add this in to test patients with respiratory symptoms and compare it to usual care. And what we saw overall was that it didn't make a big impact, that most of these studies did not show differences in antibiotic prescribing rates, in stewardship, in outcomes. And so the data was not really supportive that using this led to major changes in provider behavior or patient care. But when we look at a different subset of literature where we're using multiplex PCR that tests for viruses and bacteria together, now we start to see some positive impacts. And in the hospital, we see obviously faster turnaround because this is a fast test compared to culture and other things. In this pretty big study, they actually were able to reduce length of stay by almost a full day in the hospital. And if you work on the inpatient side of things, that's a big deal for a health system, just because we were able to know what these patients had faster and manage them in the right way better. And so this data is helpful. And the overall inference here is that just being shown that you have a virus, again, it doesn't give providers enough confidence to not worry that you might have something else or that you might get really sick from a bacteria if you're one of those 10% or 20%. But when we can confidently say you have a virus and you do not have bacteria, that leads to meaningful impacts in our antibiotic use and our overall patient outcomes. So that's encouraging data. And that has really led into what we have done here at Industry Lab. And this has been a process for about 9 or 12 months, really since last respiratory season, where we sat down and took a look and said, how can we, again, be part of the solution to this respiratory conundrum? How can we do things differently? How can we wrap PCR in innovative ways to serve providers and patients better? And the 3 tenets that kind of guided us in rethinking this were, number 1, it has to be clinically relevant. No more testing for obscure viruses or obscure pathogens that sometimes you see on these panels that don't make meaningful change. That just adds to cost. It doesn't add value to care. Let's get rid of that and make sure we're testing for relevant pathogens. Number 2, patients are not one size fits all. So we should not just simply order or have available one respiratory test. Different patients have different needs. Number three is, how can we increase equity in healthcare? And this is a broad question, of course, but from our corner of healthcare, how can we make PCR technology more accessible to more patients in more areas of the healthcare system? And so that led to the creation of not one, but 5 respiratory products. And I'm kind of showing the bookends here to start. Of course, we have a COVID test, just an isolated COVID test that will certainly be necessary still for people for travel and whatever, to be able to say, do I have COVID or not? So of course we have that available. And on the other end, we have our comprehensive test that really runs the gamut of respiratory viruses and the 9 top bacterial causes of upper and lower respiratory tract infection. And this is all data supported and epidemiology data driven to create this panel. And this, again, I like to think of this for the patients who you can't afford to miss. So I tend to think of those elderly patients or the pediatric patients or the patients with lung disease, immunocompromised patients who, if you're wrong, if you say you have viral, and you miss one, these are the people who would get sick and could get hospitalized, etc. So I think there's a very important place for this test, though I don't think it is for every patient. And so that has led to the creation of a few other offerings that we have. The first is non-viral, and it is a strep test, essentially. And it is useful for PCR diagnosis or confirmation of strep pyogenes, which is group A strep, or what causes strep throat and strep pharyngitis, but also that we can identify strep and then differentiate what it is. And knowing that you have strep pneumoniae matters in some populations, especially the elderly, or knowing that the strep that you have is one of these more colonizing streps that you have to worry less about in terms of causing infection. So we have this available as an offering. We then, of course, said, what are the things that we're most worried about in healthcare, in respiratory infection globally? Obviously, it's these 3 things. And we talked about these a lot at the beginning. A lot of patients are going to have symptoms and want to know, do you have the flu? Do you have COVID? And do you have RSV? So again, we didn't feel like we needed to make somebody test for all of this stuff if they were really interested in these 3 things. So we said, let's create this. And this is Fluvid RSV at Industry Lab, designed specifically to look for these common and very high acuity viruses. And our 4th product is the one that I'm the most excited about. This is our rapid reflex product. And you can obviously see just by number of pathogens, we're kind of in between Fluvid and we're in between and our comprehensive test in terms of what we're testing. But what I really like is the way that we go about testing. And this is really innovative. I think this is the first time, certainly I've ever seen this done in PCR. And this is really what was born out of these tenets of how can we do this. And so I want to unpack this a little more. We have introduced sequential PCR testing, essentially, where we will look for things that are common first and then proceed to test additionally if additional testing is required. So think of a patient with COVID, but think of maybe an elderly patient who seems like they have COVID and their family had COVID, and now, grandma has COVID because she was with the grandkids last week and they tested positive. So sure, I could send an isolated COVID test, but what do I do if that's negative, right? And she still has symptoms. I could send the Fluvid RSV test and rule out all 3 of these. But what if it is negative? And this is what rapid reflex will say, is that if she has COVID, we're going to test for these level 1 pathogens first. And if she has COVID, then we will confirm that and the test is complete. And as such, the bill is complete and the charge for this test is complete. So this allows us to have a robust PCR test for a fraction of what PCR generally costs in the healthcare world. And this is that equity portion of our goal, is to make this more accessible. However, what if she's negative, right? In other tests, we don't have more answers. With rapid reflex, we can give you more answers, because if these are negative, we will go to level 2 automatically and test for the next wave of common viruses, so that we can say you don't have COVID, but you do have adenovirus. So you can confidently manage that patient with a viral infection. If those are negative, we'll continue to test, and now we'll start to look for the bacterial causes of infection. So you can rest assured in those patients, I like to think of the patient that fits this bill as it's probably viral, but, right? You probably have one of these common things, but I don't want to miss it if you have something else or something that could make you sicker. And that's exactly what this is designed for, is to find those people who have those infections. We can run the resistance testing on here and tell you how to treat these bacteria. But for the majority, for the 80% of patients who those viral symptoms are going to be indeed viral, we can limit the cost of PCR technology and make PCR more accessible to more patients. So we're really excited about introducing this new way of thinking of PCR testing and doing it sequentially to hopefully make it more accessible to a broader array of patients. And so finally, I just want to kind of show a couple of anecdotes really of some places that have already come to us and said, this is how we're using these products. And the first is primary care. And I'm not projecting this. This is not evidence-based. This is just what some folks already this respiratory season have come to us and said what they're doing differently. Their conventional approach, they readily acknowledge. Most of the patients we see are otherwise healthy. They very much likely have a viral infection. But for any number of reasons, the ones that we looked at before, they leave with antibiotics. We know that we prescribe them, but we don't have anything else. Sometimes we have a rapid test we can use. Sometimes we send cultures and we can follow up on that. But we know that we give a lot of antibiotics. And what they have said is we have now switched our mentality in viewing these patients. And we have taken a hard stance to say, if you look viral, we're going to treat you as viral. And you are not going to get antibiotics. And instead, I'm going to swab you and I'm going to send for this rapid reflex test. And if tomorrow I learn that you have bacteria, you're going to get a phone call from me and I'm going to call you in some antibiotics and we're going to get you on the right treatment. If you don't hear from me, this test confirmed that you have what we think you have, which is a virus. And they suspect, just based on their prescribing habits, that for every one patient that maybe has a one-day delay in starting those antibiotics, right, because you're waiting for confirmation tomorrow, which is still pretty fast, they think they'll save 5 or 10 antibiotic prescriptions. And they're excited to track this data and see what they're prescribing, what changes in their antibiotic use this respiratory season, because they have, something at their disposal now that they can use in real time. On the other end of the spectrum, a long-term care has come back to us and admits, again, that they have pretty liberal infectious precautions, as they must, and they isolate quickly and they go into droplet precautions quickly, as you have to in those environments. They know a lot of what they see is viral too, but they can't afford to miss bacterial, obviously, in their high-risk population. So they do a lot of testing. They even said they do a lot of imaging. They do a lot of early chest x-ray to try and just have some data to support if this patient has pneumonia or not. And as such, they use a lot of broad antibiotics. And they said it's just the way that it is. And we acknowledge that it's not great. But they've said with the advent or the introduction of these tests, they've almost gotten rid of their early chest x-ray in their entirety, is what they have told us. And they've said they've kind of substituted that for this. And again, I'm not plugging this as an evidence-based thing, but they have just said subjectively, the yield from these chest x-rays is not that great. And if I can know tomorrow that there's bacteria in there, yes or no, or there's viruses in there, yes or no, we don't feel like we need a lot of pan x-raying of these elderly patients. So the efficiency that's created, the less radiology, obviously, is always a good thing. And they know that when we find bacterial infection, we will be able to tell them what antibiotics are in and out, because we can test for the resistance markers as well. They've even found that they can reduce their unnecessary isolation. Because again, you think of the influenza patient who looks like they have the flu, and the woman down the hall has the flu, but the flu test is negative. That rapid antigen test is negative. That patient is still going to be in isolation for a long time, because we know that test might be wrong. They say they can bank on PCR results, and they can take a negative PCR result for influenza at face value and get patients out of isolation faster. In some cases, which obviously would be a good thing. So just to highlight a few examples that we've already seen where this is the ability to fill this void with a rapid, accurate, and either very comprehensive or rapid reflex test has been able to lead to some practice changes and presumably better care and better stewardship in some of these populations. So to summarize, we know that respiratory is generally a discussion of bacterial versus viral. and that it is all of our jobs to try to answer this question better so we can use antibiotics more appropriately for the good of all of our community health. Multiplex PCR is really not new to this space, but most of us or still think of it kind of as just a COVID test, kind of a one-off thing, or as a broad testing panel. Not all patients are the same. We know that, and so we have tailored our products to this, and especially rapid reflex, that we're really excited to see how this can impact care. So the final plug, again, one more support for us as a clinical lab. We have this Report RX feature, and we want to make sure that PCR results are impacting patients positively. We recognize that PCR is kind of a new language still for some of us, and so we want to help with that. If you get a PCR report that is confusing, or you're not sure what you're looking at, or you want to confirm how to manage this patient, or maybe your patient has 20 allergies, or they're on dialysis, we want to help with that. So we are available all the time to look at these things with you, to help educate in the moment and make sure that you are able to use these great PCR results, this great technology, for the best outcomes for your patients. And with that said, I will turn it back over to Kira to see if we've had any questions. I haven't been able to see the chat as we've been going, but thanks so much for your attention. And yeah, let's see if there's some discussion to be had for the last couple minutes here.
Yeah, as always, CJ, great presentation. I think it's always nice to kind of give everybody that refresher on some of the things that we're probably familiar with and aware of, and then talk about those trends so that we can figure out what all of us can do to help make this a better respiratory season for everybody. We did have 3 questions come through. So it looks like we had one come through. Hi, Monica Stormont's office. Glad you guys could join us today. We saw that you asked for the slide deck. We can definitely get that over to you. If you don't mind just sending another Q&A through with an email address, CJ can send that over as soon as we're done here today. If anybody else wants a copy of the slide deck, go ahead and use that Q&A function to submit an email address, and we'll make sure we get that over to you. As for the recording today, we'll put this up on our YouTube channel by 5 o'clock this evening. So you can actually find us on YouTube. If you just search Industry Lab, this will come up for you. On to the next question. So this, CJ, this one's for you. How do you see PCR testing fitting in with the point of care tests we use in the office? Is it replacing those, or is it working with those?
Yeah, it's a good question. And we just kind of unpacked it, but not fully. So I appreciate that question. I don't think it's a replacement, at least not yet. I don't think the data supports that PCR is a replacement for those. Because again, you can't beat the speed, the expense. Obviously, they're cheaper tests to run, and they're very easy to use. And when they're positive, they can give you good information, and they can help confirm some clinical suspicion when they're positive. The main drawback is, again, as highlighted, that negative result, because you're left saying, well, can I believe this negative result? So I think there's room to work in tandem, really, that test can be used for a lot of patients, and in a percentage of them, it will yield really good usable results. But that maybe it becomes kind of a reflex almost, where if this patient looks like they've got of the flu, for example, and that flu test is negative, it's just a quick PCR reflex to confirm that negative. Or if a patient really wants to know, or if the provider really wants to have confidence in making that assessment, that PCR can be kind of the next step, and still not be too late to be usable. To have results the day after would still be relevant in managing that patient. So that's a great question. I don't think I certainly would not say go throw out your machines. You don't need them anymore, because the data certainly does not support that. And I think there's a good mix, and it depends where you're practicing too. In an urgent care versus a primary care versus a long-term care, is probably for you to kind of figure out what makes most sense for your population. But certainly there's benefits to both. Yeah, good question.
Awesome. So our final question, unless we get a couple more coming through here, again, feel free to submit these if you guys think of anything else. This one says, you mentioned respiratory PCR having a potential impact on C. diff infections. I missed the connection there. Could you please explain?
Yeah. Sorry, kind of glossed over that, and it's a couple of degrees away. But the idea just highlights C. diff as kind of a very severe complication of antibiotics. Essentially to drive home the point that we need to use less antibiotics overall, because without a doubt, if you see respiratory patients, this is how an infectious disease physician, one of my mentors, would teach it to us and to anybody that he taught. He said, if you have never caused C. diff in a patient, then you just don't know that you have caused C. diff in a patient. If you prescribe antibiotics, you have caused C. diff before. And I just highlighted, obviously, all antibiotics that we take orally, the majority of them will have an effect on the gut. And if you have C. diff in there and you upset that balance, you can allow C. diff to predominate and cause, clinical disease. And we just know that C. diff can be mild, but it can be pesky, it can be recurrent, or especially in the elderly, it can be really severe, and it can cause death. And so that was highlighted essentially just to say, if we were better stewards of antibiotics in respiratory infections, something that we do not correlate with C. diff, we could actually make a tangible difference in that other outcome. So just to highlight that stewardship is needed for a lot of reasons, and C. diff would be one of them. So sorry, we went over that kind of quickly, but yeah, that's a great question.
Awesome. Well, I don't see any more questions here. So we'll kind of pop over to our last slide that we have here. This is just some ways you guys can get in touch with us. If you have any other outstanding questions, maybe don't want to ask them here, or if you'd like to schedule some time with one of our representatives, we're all over the state of Ohio. We can get somebody to you within 24 to 48 hours. So if that's something you're interested in, you can either go to our website and submit a inquiry there. You can send us an email directly. That's probably going to be the quickest, along with calling our office, or you can call the Report RX line there. That'll connect you directly with CJ, and he can help facilitate some of that as well. So again, happy to connect you with somebody, dive a little deeper into some of these things. And if you don't currently work with us, we'd love to discuss some ways that we can partner together and make this a successful respiratory season. So if anybody doesn't have anything else, I think that wraps things up for today. Again, thank you guys so much for joining us today. We know you're all very busy. We hope this was informative for everybody. So thank you again. Have a great day, everybody.
Yeah. Thanks, everybody. Stay healthy. Bye-bye.